Hello, Mr. Holmes. The doctor will see you now.
Good morning, Mr. Holmes. I'm Dr. Achilles. What have you come to see me about today?
I actually prefer to be called Dr. Holmes, but I've come in with a bit of pain down the back of my leg here.
Okay, and how did you go about doing that?
The incident occurred actually at a birthday party just a few short days ago.
This isn't a party. We need to play the balloon popping game.
Yeah! Come on!
Yeah!
Come on!
Indeed!
What you say? That you only meant well, 'cause you did. What you say? That it's all for the best, 'cause it is. What you say? That it's just what we need. You decided this. What you say?
Come on! I gotta do this myself. Oh shit! I'm bad. I'm in a bad.
Dr. Holmes,
Sorry.
that's alright. From what you've just told me, it sounds like you may have injured your Achilles tendon.
When you forcefully plan to flex your ankle whilst trying to pop a balloon during the balloon popping game.
So what we're going to need to do is do a quick examination and then possibly send you off for an ultrasound to confirm if it's been torn or anything.
Sounds good.
Okay, Mr. Holmes.
Doctor.
Right, sorry. I'll just get you to lie face down and we'll do a Thompson test to see if you've ruptured your Achilles. So what I need to do here is squeeze the muscle belly of the calf, and if we observe plantar flexion like we do on the good side here, then we know that the Achilles tendon is intact. But on the bad side here, we won't witness any plantar flexion, which indicates that there's a tear in your Achilles. What I'm going to do now is just test the strength of your calf. What we'll notice if you push down into my hand, on the good side, you've got strength intact with the plantar flexion. But on the bad side, you've got a loss in that plantar flexion strength, indicating an Achilles tear. Now we're going to be feeling for a palpable gap in your Achilles tendon. On the good side here, the tendon is intact. But on the bad side, where you've got a grade 3 rupture, there is quite a noticeable gap in the Achilles tendon. I'm going to be taking the ankle into passive dorsiflexion. What we'll find is an increase in this passive dorsiflexion, which indicates a tear in the Achilles tendon.
So after the examination that was done and the history which you've just given us, what I think is going on is that you've ruptured your Achilles tendon. Okay? The Achilles tendon is located just posterior to your ankle or behind the ankle, and it's the union of the muscles of the calf connecting it to the lower aspect of the foot, enabling you to do what we call plantar flexion, or that movement of your foot. Without the ability to do that, and with the severing of the Achilles tendon, you're unable to do that movement, and it thus affects your ability to walk, your posture, and weight distribution. So Achilles tendon ruptures are quite common, and degeneration of them is also quite common. In terms of severity, they're graded from 1 to 3, 1 being least severe, 3 being most severe. What it's like is that if you were to imagine a string, grade 1 is a few of the fibres have cut off. Grade 2 is a few more fibres are broken off with a little bit more functional loss. And grade 3 is where you have complete severing of the Achilles tendon itself, resulting in complete functional loss, which is what you've got.
Okay, Dr. Achilles, what can I do to fix this problem?
The options you have are surgery, or the most conservative option, which involves immobilising the ankle for 6 to 8 weeks.
Which one would you recommend?
I believe the best course of action will be for you to undergo percutaneous surgery.
Alright, what does that involve?
This involves 3 small incisions either side of the damaged Achilles tendon, where the Achilles is positioned now and where the surgeon would like to reattach it. It is then sutured together through these small incisions, which therefore limits how invasive the procedure will be.
That sounds like it could have some complications. What would they be?
Some of the complications include infection, blood clots, pain and bleeding, decreased range through the ankle. And some of the more specific complications with this particular surgery are a slightly lower success rate due to decreased ability to visualise a tendon during surgery, a higher tendency to re-rupture when playing high-level sport, but compared with open surgery, percutaneous surgery reduces the risk of complications such as infections and has a better cosmetic benefit for you. Overall, I believe you should undergo percutaneous surgery, and this is due to the fact that it is less invasive, there is less risk of complications due to the smaller incisions, and due to the main fact that you will not be performing a high-level sport.
That sounds good. Is there anything I can do after the surgery to increase my recovery? And how long will it take?
I would advise you to begin range of motion exercises 72 hours after surgery, so just gently. For the next 2 weeks, you will need to stay off your foot and wear a posterior splint. This will help to keep your ankle in a controlled dorsiflex position. After those 2 weeks, you may return to normal walking while wearing a hinged orthosis, which is commonly known as a moon boot. 6 weeks after surgery, we will get you off the boot and return to normal walking with full weight bearing, and from here you'll be able to begin some resistance exercise. We will then begin pool running, and this will continue up until 12 weeks post-surgery, and from there you can commence jogging, or as we in the medical field pronounce it, yogging.
Of course, yeah.
It will then be close to 6 months for you until you can get back to your pre-injury state.
That sounds good, Dr. Achilles. Thank you for your consultation today.
Thank you, Doctor, for getting me back to full health. I appreciate it. I've got to run today because I've got to go to my orthopaedics class, but I'll see you in a couple of weeks for my checkup.
No worries. All the best.
Thank you.